ತುಮಕೂರು ಅವರು ಶುರು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಈ ಕಾರ್ಯಕ್ರಮ ಶುರು ಮಾಡೋಕ್ಕಿಂತ ಮುಂಚೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆಯೊಂದಿಗೆ ನಾವು ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಮುಂದುವರಿಸೋಣ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನು ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ. Over to Dr. Mahesh. You can introduce.
I welcome. One second, sir. Lokesh Babu is not audible from our side.
This is the
Please.
volume.
Technical problem.
ಕೇಳಿಸ್ತಾ ಇದೆ ಮಹೇಶ್, ಕೇಳಿಸ್ತಾ ಇದೆ.
ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
ಅವ್ರದ್ದು ಮ್ಯೂಟ್
ಲೋಕೇಶ್
ಆಗಿಲ್ಲ.
ಬಾಬು.
ಅವರೇ
ಕೇಳಿಸ್ತಾ ಇದೆ ಸರ್, ಅವ್ರದ್ದು ಕೇಳಿಸ್ತಾ ಇದೆ. ಲೋಕೇಶ್ ಸರ್ ಕೇಳಿಸ್ತಾ ಇದೆ.
Lokesh Babu.
ಈಸ್ ಆಡಿಬಲ್.
No, he is
Go ahead,
audible to us, sir. We are not audible to him, it seems.
Oh,
Sir, we are not audible to him, it seems. So, 1 minute, sir.
Sir, it is good. He can just rejoin once again.
What is this thumbnail?
ಕೇಳಿಸ್ತಾ ಇದೆ ಸರ್ ಲೋಕೇಶ್ ಬಾಬು ಅವರದು.
ಹೇಳಮ್ಮ.
ಒಂದು ಇದು ಮಾಡಿ ಕ್ಯಾನ್ಸಲ್ ಮಾಡಿ ಮತ್ತೆ ರೀಜಾಯಿನ್ ಆಗ್ಬೇಕಂತ.
ಹೌದಾ? ಓಕೆ. ಎಕ್ಸಿಟ್ ಆಗಿ ಮಾಡಬೇಕು. ಸ್ಟಾಪ್ ಶೇರ್ ಮಾಡಿ ಫಸ್ಟ್.
Hello, sir. Lokesh Babu, sir.
ಮ್ಯೂಟ್ ನಲ್ಲಿ ಇದ್ದಾರೆ ಸರ್.
ಅವ್ರು ಎಕ್ಸಿಟ್ ಆದ್ರು.
ಅದು ಎಕ್ಸಿಟ್ ಆಗಿ ಒಂದ್ಸರಿ ರೀಜನ್ ಆಗ್ಬೋದು ಸರ್.
ಅದೇ ರೀಸನ್ ಆಗ್ಬೇಕು ಹೇಳಿದ್ರು.
ಎಸ್ ಸರ್.
ಜಾನ್, ನೀವು ಕೋ ಹೋಸ್ಟಾ?
ಎಸ್ ಸರ್.
ನೀವು ಕೋ ಹೋಸ್ಟಾ?
ಇಲ್ಲ ಸರ್, ಐ ಆಮ್ ದ ಹೋಸ್ಟ್. ಐ ಮೇಡ್ ಹಿಮ್ ಕೋ ಹೋಸ್ಟ್ ಆಲ್ರೆಡಿ.
ಓಕೆ.
ಸಮ್ ಪ್ರಾಬ್ಲಮ್ ವಿತ್ ಹಿಸ್ ಆಡಿಯೋ ಸರ್.
ನೀವು ಸ್ಲೈಡ್ ಎಲ್ಲ ನೀವು ಇಟ್ಕೊಂಡಿದ್ದೀರ ತಾನೆ?
ಇದೆ ಸರ್, ರೆಡಿ ಇದೆ.
Screen. Where's the screen?
Lokesh sir, can you hear us?
ಮಹೇಶ,
Lokesh sir.
ಅಲ್ಲ ಅದು ಅಲ್ಲಿ ಸ್ಲೈಡ್ ಬಂತಾ ನಿಮ್ಗೆ? ಸ್ಲೈಡ್ ಕಾಣಿಸ್ತಾ ಇದೆಯಾ? ಹೌದಾ?
ಓಪನ್
ಸ್ಲೈಡ್
ಆಗ್ತಾ ಇದೆ.
ಶೇರ್ ಮಾಡಿದೀನಿ ನೋಡು, ಅವ್ರಿಗೆ ಹೇಳು.
ಓಪನ್ ಆಗ್ತಾ
ಸ್ಲೈಡ್
ಇದೆ
ಕಾಣ್ತಾ ಇದೆ. ಕೇಳಿಸ್ತಾ ಇಲ್ಲ ಲೋಕಿ? ಸ್ಲೈಡ್ ಕಾಣಿಸುತ್ತೆ.
ಕಾಣಿಸ್ತಾ ಇದೆ ಅಲ್ವಾ ಲೋಕೇಶ್ ಬಾಬು ಅಂತ?
ಕೇಳಿಸ್ತಾ ಇದೆ. ಯಾ ವಿ ಕ್ಯಾನ್ ಸಿ ದ ಸ್ಲೈಡ್ಸ್. ನೋ
We
ಪ್ರಾಬ್ಲಮ್.
can see and we can
So,
hear it
ನಿಮ್ದು
loud and
ಕ್ವಶನ್
clear,
ಆನ್ಸರ್
Lokesh
ಸೆಷನ್
Babu sir.
ಮಾತ್ರ ನೀವು ಬೇಕಾದ್ರೆ ಮೈಕ್ ಬೇಕಾಗುತ್ತೆ ಅಷ್ಟೇ, ಸ್ಪೀಕರ್. ಅವಾಗ ನೋಡೋಣ. ಈಗ ಸದ್ಯಕ್ಕೆ ನಾನು ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತೀನಿ.
he can
We can
start.
put
Yes,
it in
sir.
the chat box if there is questions.
Yes, sir. You can go ahead.
That can be done. That can be done. If there is
ಇಲ್ಲ,
audio
ಚಾಟ್ ಅಲ್ಲಿ
issue.
ಮೆಸೇಜ್ ಕ್ವಶನ್ಸ್ ಹಾಕಿದ್ರೆ ನೋಡ್ಕೊಂತೀನಿ.
Yes, sir.
Yeah.
ಏನೋ ಪ್ರಾಬ್ಲಮ್ ಇದೆ
Yes, sir.
ಅಂತ
Yes.
ಸ್ಪೀಕರ್.
Yes, sir.
We can start, sir.
Before starting the program, I request Dr. Mahesh to introduce the.
You just see there is
Yes,
any
sir.
speed.
I
And,
welcome.
Welcome address by our President, Dr. Veerbhadra, sir.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಈ ದಿನದ CGPಯ ಮೊದಲ ವೆಬಿನಾರ್ಗೆ ತಮ್ಮೆಲ್ಲರಿಗೂ ಹಾರ್ದಿಕವಾಗಿ ಸ್ವಾಗತಿಸ್ತೇನೆ. ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಅವರು ಲೋಕೇಶ್ ಬಾಬು ಅವರ ವ್ಯಕ್ತಿ ಪರಿಚಯ ಮಾಡ್ಕೊಡ್ಬೇಕಂತ ಕೇಳ್ಕೊತೀನಿ.
Thank you, sir.
Okay.
Dr. Lokesh Babu, native of Tumkur, founder director of Sneha Mano Vikasa Kendra Hospital, Tumkur. Is the dedication and providing holistic psychiatric care for mental health since 2003. He is also president of Sejal New Life Foundation charitable organization. With this organization, he has done more than 500 free mental health camps and organized more than 1,000 mental health awareness lectures all over the Karnataka. He has been organized for various institutions. And Dr. Lokesh Babu has been a mental expert for various TV channel discussions like Public TV, Suvarna TV, BTV, TV Pragati, and so on. Worked for Tumkur IMA as since 2003, and he was the vice president, joint secretary, and also the EC member, and he is also the president elect for 26-27. So I welcome Dr. Lokesh Babu to give the talk on the mental health condition. So I welcome him, sir. So I welcome Dr. Lokesh Babu, sir. Please continue, sir. Lokesh Babu.
You already sharing it, sir.
Mahesh sir, I think we should call him and tell he can go ahead and because he can't hear us.
Okay, sir.
Sir, start ಮಾಡ್ಲಾ? Okay, sir, thank you.
Sir, Lokesh sir, start ಮಾಡಿ.
Good evening, everybody. And I would like to first of all, I would like to thank Dr. Veerbhadraya, TA, who has been a state president, for giving me this opportunity. And when Dr. Mahesh was communicating with me since a long time, actually, he said this has become a dormant, so we need to restart again the medical education on system. So I was very happy, and I'm happy that this is the first lecture for this season. And I welcome all of you who are present there, and I can see a lot of my friends, David and Subrata, the current secretary of Shimaga, and thank you very much for being there. So I am Dr. Lokesh Babu. I finished my psychiatry from Father Muller's. So today's basically talk is concised about what are severe mental health conditions and what are common mild mental health conditions, and basic focus on the major ones, because whole of psychiatry to cover it would be a most difficult task. So I'll just focus on what is essential in the general practicing system. So there are like broadly it has been classified into two. There is a severe mental disorder and common mental, like, you know, disorders, which are like maybe like 1 in 5 person may suffer from those kind of conditions. So in the severe mental disorder, Like what happens is like, for example, schizophrenia and mood disorders, where there is severity of the illness is very tremendous, where person will lose in touch with the reality. Like they may not, sometimes they may not identify themselves also, and they'll have delusions and hallucinations. And common disorders like neurotic disorders, what happens, the person knows what is the problem that he has. Sometimes he'll attribute it to the outside reasons, or sometimes he may not be considering that it may require some any kind of a help. So that is the change, difference between the severe mental disorders and the common mental disorders. So basically, the person who doesn't know that he has any psychiatric, of course, sometimes we say that egoistic people also don't know like what they have, they don't agree with whatever they have and stuff like that. But in reality, it is a capacity of the brain which is compromised to recognize its own pathology. So that's what becomes severe mental disorders. So usually they are brought by others rather than coming himself. And the neurotic disorders, usually we all go by ourselves. Like I'm not able to sleep, or I have a difficulty in performing function. So many types. And disturbance of the family and community is more common with severe mental disorders, whether in the common mental disorder, neurotic disorders, they suffer to self most of the time. And of course, sometimes borderline personality, antisocial personality, sometimes even the community gets involved in it. But the intensity and severities are very different actually. So there is a sleep disturbance, maybe both, it is common in both the conditions. And also 1% of the population are affected by the severe mental disorders, whereas 10 to more than 10% people are affected by the neurotic disorders. So, of course, in both the conditions, biological is the main reason, but sometimes what happens in socio-cultural environment also influences very strongly in the neurotic disorders. Whereas severe mental disorders, most of the time there will be an vulnerability for genetic vulnerability will be there for the disease. And the treatment pattern, like for neurotic disorders, we may have a counseling, yoga, medications, behavioral therapy, a lot of other things can be done. Whereas in severe mental disorders, they absolutely need medications. And also sometimes if it is very severe, harmful to themselves or harmful to others, sometimes we require medications along with the electroconvulsive therapy, which is still in the greater practice among us. So, what are the common mental disorders or the neurotic disorders, so called? So, one is the most common, we all know, depression is when we watch television, or currently, like all the celebrities are coming out with their psychiatric problems, like including Amir Khan. They all say that they have depression, they had depression otherwise. And general anxiety disorders, which are the most prevalent ones, which are hardly recognized and diagnosed, that person is having an anxiety, because most of the anxiety disorders are considered as a normal part of the behavior. And also in our culture, there is a promotion of anxiety disorders, like, are you not scared of the elders, are you not scared of your exams, are you not scared of that? So in the family itself, they create so much of they promote anxiety as a method to achieve the goals. So sometimes it doesn't work out that way, so a person may indulge in so much of anxiety, it may become very harmful to him, decapacitating sometimes. The OCD actually, it is most common and less recognized. There are a lot of types of OCDs which are there actually, and all we know certain OCDs are like washing hands, and they're the major OCDs which we recognize. Then we have PTSD, post-traumatic stress disorder, adjustment disorders, which are very common actually, and dissociative disorders, like recent movies. If you have watched the Sue from the Sulochana, that movie where that person will be possessed by the woman who was dead to get her married. Like dissociation means Usually, partial insight will be there with the person who will be partially aware about the happenings of what is happening in his life, and also they won't be able to regulate their behavior once they go into the dissociation. Now, it is not a drama, or it's not an acting. The person, to avoid some kind of a discomfort, he gets into that behavior. And the somatoform disorders, like all the psychological disorders, when they are not addressed, emotions which are not addressed, anger, sadness, lot of emotions in our Indian culture are not permitted actually to express. Like if a son is crying or a daughter is crying, usually parents feel very uncomfortable when the children cry. They suddenly try to rescue them, and they want them to stop crying or stop getting angry. So what happens in childhood itself, so many emotions are not permitted per se to experience. So that becomes a big problem as we grow up as an adult to have a healthy relationship. So that is one problem that we will have actually. And adjustment disorders, as I mentioned, and somatoform disorders are also the main significant things. So, like, if I feel sad one day, like, then do you think that I have a depression? Okay, that is the most common thing. Everybody asks, or everybody will go through the loss and they all feel sad. But why do you, how do you say that it is a medical reason? Because everybody feels sad in life. So, if in that way, like, according to you, everybody is mentally ill. So, that is the common debate that we will have with our friends who are not psychiatric related, or who are not medical in the medical profession. So most important, what happens in depression is like no one diagnoses psychiatric illness rarely as we do, because for us everything has to have a criteria. It is not just the symptoms and the signs. We all feel sad, we all feel angry, we all feel scared, but that doesn't amount to a mental illness or which requires an attention. So what is the criteria? So minimum for depression, we need to have a 2 weeks of continuous illness, or most of the day, most of the time, person should be having these points, like he should be having low mood, loss of interest, easy fatigability, and reduced attention, or reduced concentration, reduced self-esteem, ideas of guilt. Like reduced self-esteem is like we have to recognize that the confident person suddenly loses his confidence. Though will be seeing, like, you are not like this before. You had so much of josh and enthusiasm and capacity and used to advise us, but why have you become like this? So even the person may also not recognize. He also say, like, even I don't know why I have become like this. So that is one of the main sign of depression. And ideas of guilt. The maybe person has not indulged in any severe form of bad behavior, but whatever the simple behavior, like I was not there, my friend, when he called me. So in the depression, it may become a very prevalent thought which comes back to me again and again and haunts me. Like, I was not a good son, I was not there when my father died. So many things. I'm not a good father. Any which are normal thoughts which are helpful for us to change our behavior. Sometimes they occur in such an intensity with a low mood, and I start feeling bad about myself, like, I'm not a worthy to live because I was not there for somebody else. I did this mistake. So that is the guilt. Guilt is very, very, very pathological. But in India, sometimes, family promotes guilt, like, are you not ashamed? Don't you feel anything? Like, these kind of words are used. So invariably, all Indian children go through this kind of a guilt that they are not good enough, or they're not good, they're not doing good enough. All these kind of stuff they may go through. So there are so many cultural issues. That's the problem with the parenting system or the social system which is existing for us. Somehow, without our awareness, we promote a lot of psychiatric illness. So because of the low mood and a lot of lack of energy, the person will have a disturbed sleep and decreased appetite, or sometimes increased appetite. You must have seen teenage young people, they eat a lot when they are sad. Whereas, and also they sometimes they oversleep. Or elderly people, they may have a less sleep and they lose all the interest in the food. And also, most significant thing is in a sexually active age, the person will lost that interest, to have any kind of intimacy with his partner, he or she, both the thing. So it becomes a kind of a painful event for them, and that sometimes without recognized, that itself becomes a biggest worry in the family and the reason for the fight between the husband and wife, when they don't recognize it's happening because of a depression, and it is a secondary loss of sexual interest rather than the primarily the person is not having any sexual problem, and the anxiety features which also can appear along with that. And we have like loss of weight, because of loss of weight or a gain, both is possible. And waking up 2 hours early than a usual time. Person usually wakes up very early. For example, if I'm waking up at 5 o'clock, I'll wake up at 2 or 3, and I'll have a very worst mood in the morning. One of the worst mood, the depression, the severe the depression, the horrible the mood in the morning. Actually, as the day progresses, they feel better, but as soon as they wake up, they will have a terrible mood actually. And waking diurnal variation will be there. Lack of pleasure, whatever used to give of fun to that person, he loses interest in that. For example, watching a movie, talking to the friends, reading a book, or all these kind of things, what he used to gain pleasure in the earlier things, he loses pleasure in all those activities, and he feels bad about that. And lack of and also lack of emotional reactivity. Sometimes what happens, people may say like, oh, no, these days you appear so dull, why are you like this, why don't you recognize what is happening with you, why don't you take help, and why don't you have some kind of a self-control regulation over your emotions. So you're sitting like a stone, you don't respond. So there will be so much of disagreement with the person's emotions. And psychomotor retardation, sometimes what happens with the person is, how to make this full screen. So sometimes what happens because of this, the person may have difficulties so in expressing his emotions. So what are types? There is a mild and moderate and severe depression. Like okay, so in the mild is what happens in the comes with the somatic. Maximum there will be like neck pain, chest pain, multiple body symptoms they mention. And earlier, whatever I mentioned, like major symptoms, too low mood and thing, and also added with 2 or 3 somatic symptoms. In the moderate, it may be with or without somatic symptoms, and 3 major symptoms will be there, and there will be 3 or 4 minor criteria. And severe, where all the things which are mentioned, all the from now, all those things may be present also, and with along with that, what we call is like a depression with psychotic features. They may have associated psychotic features of hearing voices, somebody is scolding them, and somebody like belittling them, somebody shaming them, and also sometimes they go through intense body dysmorphic, like they feel that they may don't have a, their body may not existing, and sometimes they can see their internal organs. So brain creates such a huge amount of brain creates a very disturbing emotions and also expression for the person. So these are the main things which happen in depressive disorder actually. So there is some difficulty I'm having when you people speak. I'm not able to listen. So we'll do something. So comorbidities, like what is the reversible causes for depression is like hypothyroidism, one of the main reason, and the anxiety disorders, substance use disorders, and also personality disorders. Most of the time, people who have depression, they may have anxiety also, and because of depression, without their awareness, they must become a smokers, they may become alcohol dependent, and primary, maybe they are not addictive personalities, but because of the mood disorder, they may develop these kind of problems. And also personality disorders. So dysthymia, probably we all know what is dysthymia. Dysthymia is if you see a person who is going to be retiring, or like before that 40, 45, without our awareness, we'll be working every day sincerely, we'll do our job, we'll have our social activity, everything will be appropriate, except I won't be able to enjoy that to the fullest. So we'll all feel like somehow like I'm not able to enjoy my life so much I used to, but I do everything. I'm not sad, but I'm not still not able to enjoy. So it's called kind of a chronic depression, more than 2 years when a person is in depression on mild to moderate. So what happens? They will perform all the activities as a normal individual. They'll function perfectly, but they lack the ability to enjoy the life to the fullest. And bipolar affective disorder, adjustment disorders, and OCD, they can be a differential diagnosis. So how do we treat it? Like assess the risk, mild, moderate, severe. What is the need? For example, person has a suicidal idea, suicidal intentions, then definitely he would require hospitalization and ECT. The person has got the psychotic features, definitely you would require an hospitalization. Or it is a mild depression, moderate depression, definitely it can be dealt in the OPD itself. And additionally, with medication, is it possible that if the person is educated enough, is able to cooperate and understand the language of psychotherapy, then we will engage them with psychotherapy also. Pharmacology, most commonly used drugs are SSRIs, escitalopram, fluoxetine, and usually in depression, as I mentioned, there will be a sleep problem. So cautiously, we can use benzodiazepines, especially those who are long-acting benzodiazepines are very useful. Fluoxetine was one of the oldest medication in the depression. Or 1983, it was the first antidepressant, SSRIs, which was discovered. So very safe molecules. They don't have how people say addictive capacities. People are not going to be dependent on this disease drugs forever. So this is what we are supposed to understand, because there is a lot of misunderstanding and stigma related to the psychiatric medication and treatment. The disease itself is so long lasting, so people have to take medication. It is not that once they take medication they will be dependent. For example, once we start using a reading glass, probably we'll keep using the reading glass. When we don't use the reading glass, suddenly, like after 6 months, if I don't find, suddenly I feel my eyes were better 6 months back. After using the glass, my eyes have become worst because my graded, it would have been. So, ಅದೇ ಆಗ್ತಾ ಇಲ್ಲ ಸರ್, ನೋಡಿದೆ ಒಂದು ಟ್ರೈ ಮಾಡ್ತೀನಿ ಒಂದ್ಸರಿ. Slides. One second. Sorry for the inconvenience. I am very poor in learning these things. So, okay. ಸೊ ಜಾನ್ ಹೇಳಿ ಸರ್. ನೀವೇ ಮಾಡಿಬಿಡಿ ಸರ್, ಬೆಟರ್. ಡಿಸ್ಥೈಮಿಯಾ. ಓಕೆ ಸರ್. Next, 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 next. Yeah. Yeah. Okay. So dysthymia, as I mentioned, it's a low-grade depressive disorder presenting for years, actually affects around 5% of general population. Women more affected than men. Like if you ask them, they always say, "Nam hane barappa, en madakagutte." They use words like that. And they'll be so much dedicated in the household activities. Sometimes they lose the quality of life, actually. Psychiatric disorders, what people do not understand is it is not that we are going to save a life like a life emergency, but we see the quality of the life, actually. The intervention, psychiatrist intervention, is essential to make the quality of the life better. If you are struggling to laugh, we can help you to laugh better. And if you are not able to resolve a conflict or a problem, we can help you to have a better approach towards solving the problems. If you have any of the like basic emotions, whatever we have, joy, happiness, I mean, like joy, sadness, anger, and anxiety. So how to regulate these emotions and how to regulate your thinking, faulty thinking, erroneous thinking related to that. That is the main focus, especially in the psychiatry. So most of the time, 80% of the psychiatric disorders go unnoticed as our fate, or whether our grahagati is not good, something is bad. So we use a lot of external reasons for not able to understand why it is happening to me. So that is because of the lack of awareness. So currently it is much better. So I hope this will help to recognize importance of the mental health. So next slide, sir. So somatization disorders is actually which happens along with the depression, because depression people hardly come saying that I'm feeling sad, I'm feeling hurt, and I feel like crying. Please do something to me. I feel like killing myself. Very rarely people will come and say that. They all come and say that I have a chronic chest pain, I have a chronic backache, I have a headache. Most common presentation is headache. And then they'll say, like, as soon as I wake up in the morning, my whole body hurts and won't have any energy to do the work, and also I have a difficulty in sleeping. So they attribute I'm not able to sleep, so all these problems I have in the daytime. But in reality, it is all come together. It's like syndromal. So we tell them, like, by just improving the sleep, you're not going to become better, because you need to improve your mood, and what is necessary for that is what should be done. So that is a misconception that people have. So most common among the women compared to the men, actually. Next slide, sir. So clinical features are like vague complaints, GIT complaints. Now we can see like maximum people, gastroenterologists are like so busy these days, actually. When gastroenterology was not there, I wonder like where these people were getting treated. Now for everything, people, gastritis. That is the chief complaint, gastritis, actually. Because gut brain, now you must have heard, it's becoming a very popular trend also. How brain influences our stomach and intestine, because other than brain, the most number of receptors are present, serotonin receptor are present in our gut. So that's why both have that's the reason when we have a sufficient food, we feel satisfied, actually. So there is a connection between GIT and also the brain. That's the reason sometimes it presents itself as a physical symptoms rather than an emotional symptom, if we are not well educated to express our emotions. And sexual dysfunction, as I said, maybe lack of interest and inability to perform. And pseudoneurological symptoms, sometimes burning sensation, most common presentation, there is a burning sensation all over my body, heat ಆಗ್ಬಿಟ್ಟಿದೆ ನನಗೆ ಅನ್ನೋ ತರ present ಮಾಡ್ತಾರೆ. And long, complicated, inconsistent history. Like if you ask specifically, they cannot give you anything. And also they'll have a lot of investigative reports, all the investigation would have done multiple times. And impaired social functioning, duration at least for 2 years. And to rule out organicity, is there any other problem can lead to, for example, I had one patient who had pulmonary carcinoma who presented like depression only, actually, so in the earliest stage. So there will be a lot of organic syndromes which will present and mimic like a psychiatric disorders. Next slide. So treatment is psychotherapy, basically insight-oriented psychotherapy, supportive psychotherapy, and CBT. Most of the time, when some clinicians refer cases to us, they'll call and say, "Sir, counseling madbidi, sir." The counseling is more tedious than pharmacotherapy. Like people may not know that counseling requires soldierly discipline to attain a result. It is not that we talk to them and they become better. In that case, like there would be like that is the easiest thing to do. It's not so. In the psychotherapy or counseling, we just identify and negotiate with the client. All the work will be done by him. He has to go back home. He has to be aware in the morning till evening what's happening with him. He has to make a note of it. So it is like learning one course. It's like a 3 months diploma course. So it is not counseling or we motivate them. We don't do any such kind of things in the counseling. So that is one misunderstanding that people have, that just go talk to them and you will become better. It's not so. So it is a process. I mean, that's why counseling is selected. Only selected clients get the counseling done, those who are willing to work and who have got capacity to understand that. Then we have a supportive psychotherapy where we can train the family members also how to be assistant. And cognitive behavioral therapy is most, for example, a person, if he get a chest pain, or every time he gets a chest pain, he thinks he's going to have an heart attack. So that is the thinking in the error, that he has to recognize that, okay, but he is not able to recognize. Fear is so intense because of neurochemical imbalance in the brain. It sends a wrong signal also and wrong emotion for the problem which is existing. So there, how to correct your thinking pattern and how to identify the erroneous thought and how to correct it. That is the CBT. Sometimes it goes up to 2 years if the client is very consistent with that. And pharmacotherapy is like it's easy to give them results very early in the phase. Then later we can engage them with all the psychotherapies. So best treated by a single doctor means psychiatrist. That's how, because the rapport, every time they go to a new doctor, they have to disclose a lot of information about themselves. So sometimes they feel very shy and anxious about that. So if the whoever has got a better rapport, it is better he handles the client. New symptoms are not which are not medical complaints, and additional investigation should be avoided actually, because our patients are very eager to get investigations done. Next slide. Next slide. Okay. So anxiety disorder, like anxiety is the most essential part for a survival, but when it becomes too much to the extent of disturbing day-to-day living and inability to use the complete potentialities of what that individual has got, and instead of promoting, it becomes discouraging symptoms for the individual. That is the time when the client will have a difficulty actually. So what are the symptoms which are seen on a physical level? Or like they are sometimes intense tremors, restlessness, pacing up and down, profuse sweating, palpitation, dry mouth. Especially perimenopausal women will present with these kind of things, and dizziness, urgency for maturation, and butterflies in the stomach. And psychologically hypervigilant, the person, as I mentioned, he'll be like all the time watching, like what's going to happen to me, what's going to happen to me, what's going to happen to me. That is a persistent thought. Or the mother, if she has got an anxiety disorder, it's like, oh my god, right, I have to get up and I have to do this, I have to do that, I have to do this, and she'll start screaming in the evening itself. You people don't go to bed early, so I'll have to wake up in the morning late. So many things are like intervened. It's netted in our day-to-day activities, which appear to be very a normal behavior, but the core feature would be like, are you comfortable when you are doing these things, and what is the status of your emotion? Just by asking one that simple question, we can recognize whether it is sign symptoms or it's a normal behavior. And hypervigilance, increased uh, turtle. Sometimes, like most of the time, people say, "Sir, I get scared very easily. Even if the vessel is dropped in the house, my heart stops beating." that is the kind of expression they do. The ear itself become hyper vigilant. It's always keeps the client alert and makes him very discomfortable over the period of time. Depersonalization, derealization, like sometimes patient feel that it has happened to me sometime or not. They identify, okay, I was unrealistic experiences is what I'm floating in the air, or some because it happens with the intense anxiety actually. So anxiety can actually alter all your perception for a short period of time, but throughout the process the patient is aware that this is what is happening to me. That's how it separates from the psychotic disorder to anxiety disorder. Sometimes in the early presentation the intensity of anxiety is so high, so we tend to confuse, like, is it a psychotic phenomenon or something. Apprehension, it's actually a normal behavior, but when it becomes exceeded, then definitely it becomes a bothersome thing. And irritability. So many things which we see as a normal behavioral patterns, if it is going on from morning till evening, and day after day, week after week, and month after month, then it becomes a psychiatric illness. If it is happening related to an actual situation, then it's a normal behavior. Next slide. So in that anxiety, though, we have generalized anxiety. So it is from morning till evening. That's the main thing, actually. It is not specific to any cause. As soon as I wake up in the morning, everything starts worrying. Like, I start bothering. Okay, I have to do this. I have to pay the fees. So many random thoughts will keep coming into our mind. Especially it's common in women. Free floating, pervasive, almost anxious about every possible thing all the time, and the prevalence is around 3 to 8%. You can imagine how significant it is, and more in women, and it's a chronic. What would be the common statement the husband and children would say is like, sir, sir, it's my mother is always like this. And the husband would be like, oh, you're cut one this. I mean, instead of recognizing it's a issue which the individual is going, usually we persecute them. The family members, if they're not aware, the client it's themselves are already suffering, so we add more burden to them by not recognizing their problem and also belittling their problem, actually, or making a joke about it or a mockery about it. It makes client not to share anything with the family members. So that is one problem, and it can be like almost 6 months possible that patient will feel better. Next slide. So clinical features, increased or mentioned already, apprehension, worries about the future. This is most common, like we all worry about the future. So what is wrong in that? Because it helps us to prepare. But in anxiety disorder, they worry about everything. Like morning they wake up, they'll be worried about what's going to happen at 11 o'clock, what's going to happen at 12 o'clock, what's going to happen at 10 o'clock. And they have to get their children married at the age of 25 or 26, but they're worried since 18 only. So it's everything is in excess, actually. They always feel that they are on the edge. If I don't do it now, like what's going to happen? And because of that, they keep doing mistakes. They difficulty in concentrating, fit getting, trembling, tension, headache, most common, and inability to relax, sweating, and tachycardia, because when it becomes intense, there will be an increased heartbeat and sense of dizziness. It's not actually they will have a dizziness. They feel like I may fall, I may fall, I may fall. They stop getting, especially elderly people. They do not move out of the house without a help by their any assistance. They become a burden, actually, without recognizing it's a psychiatric problem, because the dizziness can be such a housebounding phenomena. Like person cannot go out anywhere, they don't go to social functions, everywhere he feels that I'm going to fall. So but if you ask them, have you fallen anytime, they'll say no. But the fear keeps coming back to them. And the dry mouth, because usually people in anxiety, they breathe through their mouth, so which gives, and also increased vasovagal response also makes them have a dryness of the mouth. Next slide. So treatment, almost the same psychoanalytical psychotherapy. Sigmund Freud's like talk to the patient, listen to them more than you tell them anything. And JPMR is a basically muscle relaxation therapy where we systematically from head to toe we help the client to recognize, identify, focus on a part of the body, and slowly we help them to relax. Actually, it's a slow progressive muscle relaxation actually. And CBT, which I mentioned, cognitive and also behavioral therapy. Actually, pharmacology, same SSRIs and SNRIs and benzodiazepines can be used actually. Next. So one of the most dreading, see, if something is if the schizophrenia was the worse than that is OCD actually. If you see OCD patients, because they are just like us, they can communicate. At least in schizophrenia, psychosis, they don't know. Here they'll know what is happening, but they cannot stop it. That becomes such a messy situation. So obsessions are mainly based on thinking, compulsions are mainly based on behaviors. So for example, if my obsession is like you have touched something dirty, so it may contain germs. So if you don't wash your hand, you may kill your mother, father, sister, brother, anybody, child, or you may kill yourself. So you need to wash your hand. So the patient washes the hand one time and they feel like some part of their hand is left out. So they wash again. And again the thought comes like, what if you have not washed it properly? Would you like to take that chance? Then again they'll wash again. So they come until they feel satisfied. More than whether hand is clean or not clean, it is not the focus. Emotionally satisfied, emotional anxiety is reduced. Till that time they will indulge in the repetitive behavior, maybe a checking or washing or any other obsession which they hold. So it can be an idea, impulse, or an image. Sometimes the pictures of the god will keep flashing in their mind, and also along with that they'll have abusive words towards the god, which is also most common in our areas. They feel so threatened, like, why am I getting bad thoughts about the god? Why am I scolding the god? Sometimes patient come like, I'm getting a thought like I'm hitting the god with the slipper. So they go into such a frustration and they feel that god is going to curse them, and their whole family is going to suffer because of the bad thoughts this he is having. It's such a messy situation for the patient. And if you tell that to any friend or a family member, it's like, why can't you control that? I control it. Why don't you control? You're not making an effort. You're a lazy person. I mean, like, nobody gets blamed as much as psychiatric patients get blamed. Every kind. I mean, like, it is something like having a psychiatric disorder is some personal failure. We decided it as a personal failure and you're good for nothing, fellow. That is the causes more difficulty for the client to share, more information. And these thoughts are very irrational. I know that I wash my hand and I don't have to wash it again. But I can't stop it because anxiety is so strong. So even though patient knows that it is an irrational thought, but he cannot stop it. And repeatedly intruding despite the resistance. I don't want to wash it. I don't want to do that. I don't want to think like that. But I have no control over whatsoever on my thoughts or my action. Why? Because of the neurochemical imbalance, and there is a circuit which is formed actually in the brain. It is like a ring road, how we make a shortcuts and ring roads. So there are separate circuits. They exist in the brain for these things. It is not that out of the blue. There's a common idea that psychiatric problems are imagined or they are functional. Functional means people think that, okay, they're just thinking it's happening. Nobody thinks and creates a psychiatric problem for themselves. Once the problem starts, then the patient starts thinking and behaving in a different way. It is not the vice versa. And the compulsive behavior sometimes followed by obsession, relieving tensions, and making themselves feel better. Behavior is aimed at relieving the anxiety. That's why it is OCD is in the anxiety disorder. Next slide. Next slide. So themes are, as I said, contamination, washing, pathological doubt, checking, intrusive thoughts, symmetry, like room has to be clean, and we call like Suchibai syndrome. We used to call Suchi is like always cleaning, cleaning, cleaning. Suchibai syndrome is OCD, excessive cleaning. These are the, and also because of that they become so slow. Like student who has got a OCD wants to study, and he finishes his first page and he feels not satisfied. Then he go back to the first page, first sentence, again he starts and finishes the first page, and again he goes back. So he spends half an hour, 1 hour, 2 hours only reading the first page only. So that makes them very slow because of that. So that bothers extensively about his progress, even though he has enough intelligence to pass his exams. Next slide. So comorbidities, maybe because of OCD, like, oh my God, I'm not able to do, I'm keep doing this only. So because of that, they may develop depression, or there may be a depression along with that. And social phobia. See, I have a patient, like, I had a lot of patients. The OCD is like whenever I look at a woman, my eyes go to the wrong part of the body. So he's not actually looking at the wrong part of the body, but his brain deceives him, saying that you are looking at the wrong part of the body. And that person is looking back at you and thinking very, very, very bad about you. What kind of this, like, especially with a higher social education, with a higher social positioning, like managers. So they come with this kind of problem, like, sir, it has been very embarrassing for me. Then I ask them, have anybody gave you the feedback? They say, like, nobody told me, but I feel that, I really do that. It's such a shame on me. I have 2 children, I have 2 grown-up daughters. Look, this is what I do. So they feel personally bad and guilty about the act which they are not in control. Because of that, they develop a social phobia. They start avoiding. So OCD causes a lot of these, like, for example, contamination also. They stop going to the public because they may get infected. And Tourette syndrome, which is almost an organic disorder, intense OCD can be seen there, actually, like, suddenly bursting out with abusive words, and getting impulsively angry, screaming, as a part of the disorder. Sometimes they get socially offended, actually. Because of that, they stop going out of the house. Next slide. So treatment in all, like, see, what happens is there are specific receptors which are involved in that. There will be a manipulation of medication about the dosages. Like, for example, in depression we use lesser amount of antidepressant, but in OCD we use more significant higher level of the higher levels. And also we use multiple drugs. Sometimes in the OCD 2 or 3 different combinations we do, whereas in depression we may use one. So that's why, even though the drugs are the same, but the treatment is not same. Treatment keeps changing specifically to the patient with the intensity of the problem that he is suffering, actually. ERP is exposure and response prevention. Like, if the person has got a fear of contamination, make him touch the dust, and just make him sit at one place until that anxiety goes down. Most of the time, patients have ran away, they have beaten the nurse because she didn't allow her to go and wash the hands. So that is the amount of anxiety they possess within. They are like a volcano, actually. It's so disturbing, actually. So even though you see the same tablet name of the medications again and again, but it is not the same treatment, actually. Next slide. So PTSD is, of course, it's not so much diagnosed in India, but recently it is becoming very popular also, especially the children who are beaten by the parents in their childhood days in severe way. Without their awareness, they lose so much of capacity to function as a normal adults as they grow up. The consequence of severe stressful life event like war, natural catastrophes, torture, or rape, where the patient starts getting flashes of the same event, and they wake up with panic attacks of when they experience, because all the experience which happens to them later, as if it is happening to them then and there. So that is the intensity, whatever they experience on that particular day, whether it may be a fear, sadness, pain, everything re-happens to them. in the post traumatic stress disorder. So they go through, and also the fear is having the thoughts again back into their mind and having those episodes again and again, which becomes quite pathological for the client to deal. Minimum 6 months patient has to go through that. Till 1 month acute stress reaction we can make, because after the event, and if it continues, then we make it a adjustment disorder. Next slide. So clinical feature as re-experiencing dreams, avoidance, numbness. They feel emotionally numb. I don't know. I don't have any feelings, you know. I don't know. I can't respond. If somebody is crying, they say like, okay, I can't respond to that, because they have numbed their emotions actually. So they become less reactive to the what is happening, or maybe exactly opposite. They may get hyper arousal. Even simple, for example, if somebody is standing next to them, they may get so panicky that he is going to harm me right now, so what to do? So that kind of an experience they may have. They become hyper vigilant. What's happening around me may not be for like, maybe may cause some trouble for me. And depression is the most common. Depression is the most common thing in this, and also anxiety, which is a part of it actually. So next slide. So treatment would be again the same, SSRIs and paroxetine, sertraline, same thing actually. And upreaction is, you would have heard like whatever the earlier they used to do for light detection, giving an injection and later trying to elicit what is there in his subconscious mind. Okay, so then EMDR therapy and exposure therapy. Next slide. Phobias are very common, like, you know, it's maybe from the childhood you heard, like dogs, worms, insects, public, open spaces, height of the building, and being in the closed rooms. They are all phobias. Phobias are anxieties with 1,000%, like magnified into 1,000 times. You just imagine that, where the person becomes totally incapacitated to perform actually. For example, water. So many people, they don't even go closer to the waterfall or a swimming pool. So intensity is very severe actually. Next slide. So situation at that particular type, and animals, we have dogs and all the things, and natural environmental type, and blood and injection. So many people, when they donating blood, or when they in the internship also, we have seen when they see injections, they actually collapse, syncope. You know, sometimes they'll have those kind of things. Next. So different, as I mentioned, social phobia, agora open spaces, claustrophobia, and darkness. Sometimes people sleep with the lights on, and heights and flying and water. These are most. Hydrophobia is in, like, you know, rabies intensity. It is most common actually. Next. So insects, entomophobia, and snakes, it is, we all have fear of the snakes until we learn how to do that. But by just thinking about it or imagining that, so many patients will come, the snake has bitten me, they'll go for a again and again checkup. And dogs, cyanophobia, and fear of needles, and fear of blood. These are all the most common phobias which we see. There are thousands of phobias actually. These are the most common ones. Next. So treatment, again, it's the same, but modality is different, and the types of therapy which is used for these techniques, I mean, illnesses are very different. That is most important thing that we have to recognize. A specific phobia will have a specific way of intervention, which is essential. Next. So as I told you, like exposure therapy, if they are like, you know, housebound, and cognitive behavioral therapy, CBT, which is most common and which is very widely, it is practiced as an independent specialty as such. CBT is very popular and very effective tool actually. Next. So mental health in children, it's just, I have just added one slide. This is the last slide, 2 slides I have. So these are the most common. There's like a lot of psychiatric disorders, but I have taken only the most common and neurotic disorders actually. In psychotic disorders, we have schizophrenia, where there's a delusions, and whereas bipolar disorder, we have mania, which is very ecstatic and very disruptive way of presentation itself. So I have not addressed those things because it is no fun to try to do the whole textbook here. So I just you taken the most common illnesses which we can or everybody will see in their practice. So among the children, just overview. Next slide, sir. Next slide, sir. So next slide. Okay, so how the sexual and cognition, motor, speech, social, and emotion. These are the areas where the development of the child will be affected. Okay, anywhere, like so where the child will get a psychiatric illness and intervention. Any of these interventions, if we have a problem or a bias, or we are not open to the child and helpful, so they may develop any of these kind of things. Next slide. So developmental, we have language, communication, all these things, and care, affection, acceptance, appreciation, regulation, memory, and language also, like memory, rules, everything, creative thinking and imagining, analyze. I mean, all these things require a specific reading novels, playing with peers, which is not now mobile has become the greatest addiction. So all these developments are actually hampered. Yesterday, I saw a patient who has got secondary autism because of excessive use of mobile phone. Now he is like an artistic child. He cannot understand actual emotions which are expressed by his parents. His speech is delayed. His hearing is absolutely normal. So mobile also has been a greatest etiological factor to create so many psychiatric disorders in this current generation. Next slide. Next slide. Yeah, what is necessary when children have warmth and give them a freedom, and threatening them, blackmailing them when they don't do it, is even today when the patient will come to our clinic, if they have brought their children, they'll say, doctor injection kodisbidtini. Even today they do that. Actually, I tell them, like, then he will never be able to take him to the doctor when he falls sick, So that kind of what appears like a fun and comedy or a teasing or a bullying, in the long term, it becomes a psychiatric illness, actually. So we need to be very careful when we address children. Next slide. So what is type of parenting which is not essential? Authoritative, authoritarian, permissive, and neglectful. This itself is a altogether a different topic which we can engage, or any other psychiatrist can engage with this. Next slide. Yeah, this is just a basic information about there's a thinking brain, emotional brain, and how there will be interlinked. Actually, there is a electrical signals running between them. Either if the person is very logical and their emotion are stunted, actually, if the person is very emotion, their logic is stunted. Okay, it's vice versa. So there is the huge network which keeps happening between inhibitory signals and the stimuli. So how well balanced they are is what makes a child to grow up well over the period of time. Next slide. Next slide. Next slide. So what are the mental health determinants? Multiple risk factor affects mental health. The more risk factors, or like adolescents are exposed to, the greater the impact of their mental health. Risk-taking behaviors like reckless driving or smoking in the early age, drug addiction, and stubborn ODD, like defiant behaviors, stealing. All these things are risk-taking behaviors. Quality of their time, home life, and the harsh parenting sometimes, unhealthy neighborhood where the curiosity makes them get into the all bad things, exposure to adversity, poverty, abuse, violence, and bullying. All this can give rise to the earlier spoken psychiatric disorders. And the quality of relationship with peers, pressure to conform with the figures, like I need to be in the group, so I need to do and follow whatever they say, so that they'll include me. That itself becomes a gateway to a lot of bad habits. And media influence these days. Media has become the omnipotent god. All the informations are sought there. So obviously, because also there is no censoring happens. So media can influence the mental health in a very bad way. The disparity between the adolescent lived reality and their aspirations for the future, like most of every adolescent thinks he wants to become IAS officer, he wants to become a doctor, he wants to become naval officer. I mean, like they have all of us have a fantasy, but the reality when it turns out to be different, so that itself become a stressor, because he feels disappointed when he cannot match his dreams or the fantasies to the realities of current day. So that is the awareness that we have to bring in adolescents, how not to be disappointed when their aspirations are not met, and how they can work towards it in a sincere way. Next slide. So intellectual disability, just like specific learning disorders, autistic spectrum disorders, and attention deficit disorder, opposite ODD, which I mentioned just now, the conduct disorder, and emotionally depression, anxiety, somatoform, all whatever the adults I mentioned, they can be in children's also. So these are the most common presentation the children can have all these disorders. Next slide. So academic failure, why I took up this slide specifically is because any child which is struggling with the education will have a tendency to persecute them instead of advising them to go for a evaluation, psychological evaluation, IQ evaluation, or specific learning disability evaluation. If the handwriting is bad, we bully them. If the person is poor in mathematics, we bully them. I mean, like somehow our culture is based on shaming and blaming rather than recognizing, identifying, and encouraging. So the whole effort is educating everybody related to the mental health is to bring normalcy, encourage the people who are struggling, and make their life comfortable, be there for them instead of becoming one of the bully, like who has got no awareness about the suffering that they go through. Next slide. Which I mentioned actually, what happens when we become critical, usually children become self-blaming themselves, they role play the parental role. If the negative parenting influences the child, because child himself starts blaming himself in his head all the time and he doesn't do. So it leads to the low self-esteem and things which can bother them over the period of time. Next slide. So emotional disorders, which I already mentioned, depression, anxiety disorders, same. It's only a statistical significance, which is not so important for today. So I will skip this slide and go to the next slide. So now we have seen a lot of young children committing suicide. We never thought about it. Neither the thought ever flashed. And because of social media and all other activities, children are getting overly copying the behaviors of an adults, and think even though they don't know what suicide does to them, so many times they attempt suicide and they die without knowing the awareness they would be losing their life forever, because the concept of longevity of life itself has not actually formed in their brain, and they try to kill themselves. It's the biggest tragedy of this generation, so which requires intense education in the schools and among the family members. Next slide. Yeah, these are the same things actually, like because all depression or anxiety disorders, the presentation will be same. Okay, but what happens in children is it may, like because child may get more angry, easily fatigued, easily tired, and they may not be verbalize their emotions very well. They may avoid meeting people, so their presentation will be a little bit different than what happens in the adults and how they present these symptoms actually. So next slide. So behavioral disorders, they may become very impulsive, anxious, and aggressive actually. They'll become very aggressive at that age. That is the one thing which we need to recognize. Next slide. Next slide. So these are like the symptoms of the ADHD actually. The problem paying attention, teaching instructions, and they get easily distracted, daydreaming, carelessness in making notes and other things, and poor concentration. ADHD children are blamed a lot actually. They're called the very mischievous child, and they are good in sports and everything, but they are not good in education, and they're bullied because of that. and they're very impulsive, they'll have sense of humor, and they may become really like sometimes unacceptably they talk more. So these are all like things which happens to the child actually, rather than the child does that to us or present it itself. So we need to be more careful when we address these kind of children. Next slide. So thank you very much for the opportunity given. I can't actually listen on the audio. So what I will do is Dr. Mahesh can call me over the phone, or I can take up the chats and I can address the questions actually. So this is a bird view of major psychiatric disorders which I have presented, and the child itself requires a special attention. I just added. I wanted to make it 2 or 4 points, but somehow slide this was more. Thank you very much for the opportunity given. And if there are any doubts, you can mention it in the questioning. I can
Thank you, Lokesh
answer.
Babu.
Otherwise, I would like to conclude my talk. Thank you very much.
Thank you, Dr. Lokesh Babu, for your wonderful
So I'll
talk
hand it
on
over to Dr. Mahesh.
Thank you everyone for attending this CME on common health conditions, sir. I thank Dr. Veerbhadraya, sir, President, Ima Ksb, and Dr. Suri Raju, Secretary IMA KSB, and all other members of office bearers of IMA KSB. So thank you everyone, sir.
There is one question by Dr. David. Can I address that?
Yeah, please.
How do you differentiate between depression and OCD? Depression is an emotion actually, like sad, as I mentioned, like low mood, lack of interest, lack of hopelessness, worthlessness. So there is basically an emotional syndrome. Whereas in OCD, it will have the specificity is at least for 1 hour, at least for 1 hour in a day, patient should engage in activity or in those kind of thoughts which he doesn't want basically. Like I will be getting a thought of like as I mentioned, like I want to repeatedly wash the hands because I feel contaminated, or I keep counting the money 100 times. So there is a repetitive behavior, there is a impulsivity in that, and it is persistent, and the patient is aware. And here he feels sad because he's not able to control his thoughts and the behavior. It is not that sadness is the primary emotion in the OCD, because most of the time for after a long time patient will come to know that he has got a OCD actually. By the time he comes, he would have developed sadness and depression. But depression is a solely emotional syndrome, whereas OCD has got thoughts, behavior, and also emotion in it. Repetitiveness is the major feature of OCD, and the patient being not agreeable, like if he identified it as an irrational thought, that is also most important factor. This is the significant way of recognizing the difference. So depression, another question, depression treatment is for how many days and what is the chance of recurrence? See, these are all actually like, we call them like any disease which is coming out of the body. Like, it is not like, it's not like a fever, like fever happens because of virus or bacteria, but these are like coming in from the body, like, diabetes, hypertension, autoimmune disorders. And now psychiatry is considered as autoimmune disorders only due to chronic stress actually. So we do not know the duration of the treatment. Sometimes patients will recover mild to moderate. We give them 6 months therapy. With psychotherapy, they become 100% fine. They may have a recurrence actually. And major depressive disorder, at least we give 2 years. Major to moderate to severe depressive disorder, 2 years is the line of treatment. But here, unless the patient learns other modalities to deal with the disorder, like for example, physical exercises, and also yoga, meditation, and also learn to cope up with the disease, and also how to manage other activities, and also social support, family support. All these things matter significantly for a psychiatric patient to become better. That is the reason these patients suffer throughout their life, not because of the disease per se, because so many factors around them is not contributory to recover completely. So that is sometimes makes this client vulnerable to have a disease for the sustained period of time. But scientifically, mild to moderate, 3 months to 6 months, moderate to severe, we can have 1.5 year, 1 year to 1.5 year, and severe disorder to anywhere from 2 to 2.5 years, if everything is appropriate, as I mentioned right now. So that is the duration. And there will be relapse and recurrences keep happening throughout the life according to the external situations and stressors which arise out of nowhere, like, out of the blue. So preparing the client to identify early symptoms and seek help, which helps them to recover faster, actually. So thank you very much for the questions. What's the scope? Beloved Radhakrishna sir has asked, what is the scope of psychiatry? Still question has been framed. Sir, you can ask also. Now my speaker is better, sir. Now you can actually, if you want, you can ask the question. Okay, what is the scope of the psychiatry? Scope of the psychiatry is good only because with the way the government is, sir, please speak, ma'am. I think my speaker is working now. So what happens in psychiatry? Of course, scope is very good actually, but the population and doctor ratio is becoming very narrowed because of our current government policies, which are not so healthy for the future interventions. So, probably there will be, like every year now, Karnataka itself is producing 200 psychiatrists. So you see number of psychiatrists over the period of time, because psychiatrists cannot indulge in any other specialties, like general practitioner practice so many things actually, but psychiatrists cannot practice anything else other than psychiatry. So if our numbers becomes more, then obviously it's going to become a very tough job for the psychiatrists, and we are the one who are exporting maximum psychiatrists to the all over the world. So increased number here, number outside also increases. So there will be a huge amount of saturation, which we are actually predicting from here to 10 to 15 years. Probably psychiatry would be a worst profession to choose 10 years after now. But now, right now, there is a scope, definitely. But competition is going to be very huge. And it's a very specific, very limited, very targeted audience, for the psychiatry. So till 5 to 10 years, scope is good, actually. Yeah, for PG going.
Good presentation, Loke.
Thank you, David. That's also PG depends upon how passionate they are.
Dr. Lokesh Babu.
Thank you, sir. Anuradha ma'am wanted to speak something.
Any questions?
ಇಷ್ಟೊತ್ತಿಗೆ ಮಲಗ್ತಿದ್ದೆ ನೀನು ಲೆಕ್ಚರ್ ಕೇಳ್ಕೊಂಡು ಕೂತ್ಕೊಂಡಿದ್ದೀನಿ ನೋಡಿ.
Thank you very much. Friend in need is a friend indeed. There's one question. Anuradha ma'am wants to speak.
Anuradha madam, you wanted to ask a question.
No, we can't hear you, madam. We can't.
Now you can hear me?
Yes, yeah, ma'am. Please.
Yes. So it was a very good presentation. You touched on very common symptoms that our patients come with. So what take-home message I got is, our patients when they present with any symptoms, we look for a physical cause and we try to treat that. In spite of treating, they keep coming back with the same backache, with the same white discharge, same pain abdomen. And the utilization of a psychiatrist from any one of us for referral is very, very poor. The reasons being two. One, we try to manage it ourselves. Two, the patients are reluctant to go to a psychiatrist because that name brand is there. So you were speaking about saturation. In spite of the saturation being there, the utility of psychiatrist by our co-consultants is certainly not as it is required by a patient, is unless and until patient is very desperate. They don't accept the referral, or they don't come and see the psychiatrist. This is my personal opinion, and certainly I think we have so many solutions to all the practical symptoms that you spoke about. Very simple symptoms you spoke, which we all ignore and neglect. ನಮ್ಮಮ್ಮ ಹಾಗೆ ಇರ್ತಾರೆ, ನಮ್ಮಮ್ಮ ಹಾಗೇನೆ, ನನ್ನ ಮಗ ಹಾಗೇನೆ. See that ಹಾಗೇನೆ, whether it is really a psychiatric issue or not, I'm not the judge. If I go to my family doctor, they will not guide us properly because they feel that they can manage. ಏನು ತೊಂದ್ರೆ ಇಲ್ಲಮ್ಮ ನಿಮ್ಮ ಅಮ್ಮನ್ಗೆ ಹೋಗಿ is what we say. But if in case we want to refer to you again, we may not be able to do it because patient will not be ready. They will think, oh, nange ಏನು psychiatric problem illa anta. So I think round the world, round everywhere, we'll have to change the what to say that brand. Unless and until that is changed, I don't think. Suppose if I have an issue and if my people say you will go to a psychiatrist, then I'll say no. But if I genuinely understand myself and see that I'm losing out on the good life, then maybe I will agree. So that part is one message I wanted to give. So I think we doctors, when we are seeing our patients, wherever we have doubt, where we have everyone is calling you Loki, so we have our close friends who are psychiatrists. So I think we should utilize their services. If not, the patient is not coming, I think a video consultation with the patient, something we have to do. I suppose I shall start doing video consultation. I will call the psychiatrist, request. In our presence, our patients will accept. Probably we cannot, they're ready to pay also, online consultation. I think definitely, Dr. Lokesh, you did highlight on all the symptoms, which at least myself with 41 years of practice has neglected. So definitely we'll, of course, I look into the depth of it. Why this lady is coming again and again? I keep wondering. So I think psychiatrist is going to help us give better services to the patients who come to us. Thank you, Dr. Lokesh.
Thank you very much for the feedback. It's very valuable also. And the reason for the psychiatry being a stigma is like it was used as a punishment once upon a time. Whatever you say, like ಹೀಗಾದ್ರೆ ನಿಮ್ಗೆ ಧಾರವಾಡ ಕಳಿಸ್ಬಿಡ್ತೀನಿ, ನಿಮ್ಮಾನ್ಸಿಗೆ ಕಳಿಸ್ಬಿಡ್ತೀನಿ. So it was used with as a shaming word in the earlier days. So that is somehow stuck with the community. But still, the reception is much better because it's simply like if you want to resolve your conflict, please do attend them and just, I mean, once they come to us, when they feel the result and the sense of change, whole perspective, the family members, everybody will come. Next time, our first patient will come, then next whole family will come. Sir, thank you very much, sir. We are all sleeping peacefully now. She's taking care of herself now. I mean, like the house itself sets right. That's why it is a quality is what we provide. Actually, quality of living is what is we are focusing on rather than the quantity of life. Because if you have a good quality, obviously the quantity of life will also become better. Because we are still in the quantity of life thing, like, you know, living and surviving, that itself is a difficult. So we are not still focused on the quality. So it's our assessment is also is like that, on the quality of living actually. So psychiatry is basically to enhance the quality of living.
Madam, one suggestion, madam. Another madam.
Yes, sir. Really, sir.
Let us not suggest that we'll be referring to a psychiatrist. You know, we'll take up his name, madam. Loki hatra ಹೋಗಿ ಬನ್ನಿ ಒಂದ್ಸರಿ ಅಂತೇಳಿ.
ಸರ್, ಅವ್ರ ಬುದ್ಧಿವಂತರು ಗೂಗಲ್ ಮಾಡಿ ಯಾರು ಇವ್ರು ಡಾಕ್ಟರ್ ನೋಡ್ಕೊಂಡು ಏನ್ ಮೇಡಮ್ ನೀವು ಸೈಕಾಟ್ರಿಸ್ಟ್ ಬರ್ಕೊಟ್ಟಿದ್ದೀರಾ, ನಾನು ಅದಕ್ಕೆ ಹೋಗ್ಲಿ.
ಇಲ್ಲ ಮೇಡಮ್, ನಾನೀಗ ಲೋಕಿಗೆ ಹೇಳ್ಬಿಡ್ತೀನಿ, ಲೋಕಿ ಸೈಕಾಟ್ರಿಸ್ಟ್ ಅದೆಲ್ಲ ತೆಗೆದ್ಬಿಡೋ ಅಂತೇಳಿ.
ಅಲ್ಲ, whatever man is saying true only. But sometimes what happens, we just have to, like, you know, see what I tell everybody is, like, you know, somehow we forget brain is just an organ of the body. You know, it is just like a liver, kidney. It is just an organ. Just because it records the information about our own self, we abuse the brain, you know. So our brain abuses us either way. So we just have to make them believe brain is just a structure and organ which is existing like any other part of the body. Just because it remembers your name, caste, and financial position, it has got no special powers as such. So there is a misconception because of that, because we identify brain as I am the brain. So we are not the brain actually. Brain records the information related to us, and that is just a part of the information recorded like any other part of the body which keeps the score. So somehow that culturally, novel, film, everywhere we think Tale Nandu, brain Nandu. So that is that should go away. And when we recognize brain is just a part of the body and it has got functions to deliver, and emotional and thinking functions and behavioral functions are mainly with psychiatry. And if these functions are hampered, so you need to go to that particular specialist. So that becomes much easier actually to sometime to convince. Thank you, ma'am. Thank you for the feedback.
Thank you, boss.
Thank you, David. Thank you very much. Thank you, Mahesh.
Thank you.
Thank you,
Veerpadraya,
Lokesh
sir.
Babu. Thank you very much.
Yeah. Dr. Lokesh, last one,
Sir.
very good presentation actually.
Thanks.
I appreciate your presentation. See, one of the problem with psychiatric issues is either overdiagnosis or underdiagnosis. See, because sometimes, yeah, based on the history given by the patient and by two different doctors, will come to the conclusion. Sometimes they overdiagnose. Some doctors sometimes, based on the history, they underdiagnose. So here in psychiatric issue, one of the major issues is the history taking, correct? Other than
Yes.
that, there is no blood investigation to diagnose anything else. So what is your opinion on that?
Sir, that's why, like, it is the involvement of the doctor in learning about an individual that will always have. See, that's the reason we tell that new PGs which they join, we tell them like don't read like a textbook, okay? Just symptoms and treatment, symptoms and tablets. You will never be able to deal with the patient, because unless we understand from where the patient is coming from, what is his position of emotional status. So once we understand those things, then only we'll be able to provide an appropriate care. Like okay, 3 days you're not slept and 3 days you have been sleeping and 12 days, and this is what the criteria says, and I'm going to put you on this medication. Usually those patients recover, I mean, like, they don't they may show initially recovery, but on the long term it becomes very difficult for the client, because it's multifactorial. Even though they come as a symptoms, but it is multifactorial. So many things affect their life from their birth till they have visited me. So it becomes an obligation. It becomes a like a, we have to ask from his birth, even though they mention the symptoms, but the history taking mainly comprises of from whom to like whatever from his birth, whatever has been significant events which has happened. So when we have that capacity to investigate the patient, obviously that we will be able to learn more about the patient. So our decision making capacity becomes very precise, or at least if not 100%, around 80% will be able to attain to the problems of the client. So that is the clinician's discrepancy. And the more time you spend with the client and more you will be able to understand them, and more we suggest like reading a lot of books for to keep upgraded with this, and not textbooks, even though anything actually with because psychiatry is a human behavioral science. It is an emotional science. So obviously the more we know about it, more we learn about it, becomes easy for us to predict, identify, diagnose and treat the client. Medications alone can never satisfy the patient actually. And about the over diagnosis, because if everybody follows the criteria, definitely there won't be like over diagnosis. But now what happens, symptomatic diagnosis, people are started doing symptomatic diagnosis. They will show 4 symptoms, they'll make a diagnosis, so they forget about the duration of the time. And for example, somatoform is 6 months they have to have. So even if they have 3 months or 2 months, they'll make a diagnosis. So, and there is one criteria also in psychiatry, we say like mental disorder not otherwise specified. So I'm not able to arrive at any diagnosis right now, but I would like to treat the patient symptomatically for now because he is in the suffering. So later over the period of time, how the disease will evolve, according to that, I'll make a diagnosis. In psychiatry, actually, there is no need to make a diagnosis on the primary visit itself, because sometimes it becomes biased, and that's why we keep changing the diagnosis also. When we are impulsive in making diagnosis, we keep changing the diagnosis because it keeps evolving as a different problem. The patient who has come with depression may end up becoming a maniac patient or end up becoming a schizophrenic. He may become anything over the period of time. So unless we know family history plays a very significant role. Usually we say like 3-generation family if it's available. So if history taking is comprehensive, then approach will be more narrowed down and more specific, and results will be more appropriate. That's my personal experience.
Sir, there's a question in the
sir.
chat box by
Yeah, sir.
orthopedic surgeon. You need to.
Chinival sir has also, there is a question actually.
Sir, I am being an orthopedic surgeon. We see a lot of geriatric orthopedic patient.
Okay, sir.
Most of them will be having one or the other type of psychiatric diseases, and by this one by age they will be having a diffuse osteoporosis. Over that, they will be taking long-term therapy of antidepressant and this one.
Yes, sir.
How to tackle the such patient in the improvement of the bone healing, because bone healing is in a part of a stress also. If
Yes,
you have been exposed to a lot of stress, bone healing is also plays an important role if you exposed to stress. So how to overcome this type of patient who have depression with nuclear family, living a son's daughter in abroad and living the only parents in the hometown, and how to tackle such type of patients. So can you enlighten this, sir?
So 1 second, I'll just put it on the charger. Just
Okay. Sorry, sir. Given a little extra some work for you.
I think Dr. Lokesh got disconnected, sir, because of his charge problem.
Yeah, yes, sir. I can understand, sir. No, and I sent the number, sir. I'll have a contact with him, sir, personally. Not, I can understand the time
Sir,
constraint.
he is my senior, sir.
Yes, sir. Yes, sir. I understand, sir. Understand, sir.
Yeah.
ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಅವ್ರದ್ದು ಮೊಬೈಲ್ ನಂಬರ್ ಕಳ್ಸಿದ್ದಾರೆ, ನೀವು ಅದನ್ನ
Definitely, ma'am. Definitely.
ಅವ್ರು ಕನೆಕ್ಟ್ ಮಾಡ್ಬಿಡಿ ಅಲ್ವಾ.
I'll be in contact with him.
But ಅವನಿರೋ ತುಮಕೂರಲ್ಲಿ ಸರ್.
ಹೌದು ಸರ್.
ಸೂರ್ಯರಾಜು ಸರ್ ಎಂಡ್ ಮಾಡ್ತೀರಾ, ವೇಟ್ ಮಾಡೋದಾ ಹೇಗೆ?
ಇಲ್ಲ ಸರ್, ಡಿಸ್ಕಂಟಿನ್ಯೂ ಮಾಡಿ ಸರ್, ಏನಲ್ಲ. ಐ ಕ್ಯಾನ್ ಕಾಂಟ್ಯಾಕ್ಟ್ ಹಿಮ್ ಬೈ ಫೋನ್ಸ್, ನೋ ಪ್ರಾಬ್ಲಮ್. ಓಕೆ ಮ್ಯಾಮ್, ಥ್ಯಾಂಕ್ ಯು.
ವೋಟ್ ಆಫ್ ಥ್ಯಾಂಕ್ಸ್ ಮಾಡಿ ಸರ್, ಸೂರ್ಯರಾಜ್ ಸರ್.
ಸರ್ ಸೂರ್ಯರಾಜ್ ಸರ್ ಇಲ್ಲ,
ಮಹೇಶ್ ಸರೇ ಮಾಡ್ತಾರೆ ತಗೊಳ್ಳಿ ಸರ್.
ಮಹೇಶ್
Sir, on behalf of Mahesh and Dr. Lokesh, I'll do the vote of thanks, sir. Thank you all for be presenting for this wonderful presentation by Dr. Lokesh. I take this opportunity to thank everyone who all participated in whole with this 1.5 hour session. I didn't think of that it will be a 1.5 hour, Mahesh, I'll take this opportunity to thank on behalf of you to everyone.
Thank you very much.
Thank you all. Good night.
Thank you.